well, I think we may actually get started. If you could just introduce yourselves via the chat box, it would be really lovely to see who's with us today. Right. Okay, I think we'll get started. Welcome everyone. It's great that you could join us. Hopefully you're all nice and cozy on this cold and wet day, wherever you are. Today we're considering the findings of the MBRRACE Saving Lives, Improving Mothers' Care report on maternal deaths, which was published last month. And in particular, what those findings tell us about the care of migrant women who have difficulties with the English language. We're squeezing a lot in a short space of time. I'm going to start. I'm Birth Companions Director Naomi, and I'm going to start by telling you a little bit about Birth Companions and our work in this area. Before I hand on to the first of our guests, Nicola Vousden from Oxford University, who co-wrote this year's MBRRACE chapter on migrant women, and she's going to help us start to explore those findings. We'll then hear from Birth Companions Head of Policy, Kirsty Kitchen, about wider work on these issues, and our partners at King's College London, Hannah Raymond-Jones and Zainab Barry, who are leading new research on the impact of the hostile environment policies on outcomes for mothers and babies. Kirsty will then round up with some reflections on what needs to happen now in light of all this established and emerging evidence. I'm going to ask you to share your own reflections, comments and questions as we go along in the chat. Please just use the chat rather than the Q&A box, because we've got someone monitoring the chat. She's Catherine. My colleague Catherine is going to be picking up all of those comments, and it's actually easier if we just use the chat and don't bother with the Q&A. If it's a question, we'll absolutely try to get it asked and answered at the end of the session. Today is really about coming together, considering the work that we all need to do to address the huge shortfalls in care for migrant women, and indeed about forming connections. So that's definitely a big part of the event. We at Birth Companions are planning a significant focus on migrant women in coming months and years. So we're really delighted that you're joining us on this journey. Thanks, Catherine. So just a little bit about Birth Companions. We're a charity that supports and protects women who have their babies in very difficult and complex situations. They might be in prison or on probation. They may be caught up in the immigration system or have involvement from children's social care. Evidence shows us that what happens in the first 1,001 days from conception to a child's second birthday lays the foundations for the rest of their life. But for thousands of mothers in the UK, the challenges they face during this period are creating huge risks to their own health and well-being and the life chances of their babies. And we've seen that systems and services don't always understand or indeed meet the needs of mothers in these situations. In fact, often they are let down. So Birth Companions exists to fight for equity and justice for these pregnant women, mothers and their babies. And we'll know we've achieved that when all mothers have the best possible experiences of pregnancy, birth and motherhood, whatever their circumstances. Each woman attains the best possible health and well-being outcomes for herself and her children. And that law, policy, systems, services and guidance meets the needs of every woman and her baby. Birth Companions has been delighted to have helped write the lay summary for the MBRRACE reports during the past several years, and in particular to have championed calling attention to the experiences and outcomes of both women with children's social care involvement and of women in the immigration system. And in our frontline services, Birth Companions has supported migrant women for nearly 2 decades now. Many of these women are recent migrants experiencing severe disadvantage, referred to by some as vulnerable migrants, so women seeking asylum, refugee women, and those who are undocumented. And many women have no recourse to public funds. So we've seen at first hand the very significant risks created by their contact with the immigration system, and this is compounded by other factors of disadvantage. Now I'm going to hand over to Nicola Vousden from NPU to talk about the MBRRACE findings. Nicola, over to you.
Thank you. So, as I'm sure many of you on this call are aware, MBRRACE UK is the group responsible for surveillance of maternal and perinatal deaths. The figures in this year's report show that approximately 30% of women who died between 2020 to 2022 were born outside of the UK. And women from certain countries were overrepresented amongst the women who died. This includes both Pakistan and India, which are the two most common countries of birth for mothers born outside of the UK. We also undertake confidential inquiries. These are anonymous deep dives into the care that women received on a specific topic. So this regularly includes morbidity reviews, so reviews of the care of women who did not die, but may have had a near-miss health event themselves, an adverse outcome for their baby, or another adverse experience of care. And these are opportunities to look in more detail at the issues that are highlighted by the tragic deaths of others and identify the lessons to be learned. So the confidential inquiry that we're discussing today investigates the care of recently migrant women. If we go to the next slide, please. Thanks, Catherine. So in this inquiry, we looked at a sample of women who were born abroad, who had arrived in the UK less than 2 years prior to giving birth, and who were identified as having a language other than English. In total, we examined the care for 38 women, and 24 of these women had a perinatal death, and a further 2 women had a pregnancy loss in early pregnancy. I'd like to emphasise, though, that although we know there are inequalities in perinatal outcomes, the high proportion of women who had a perinatal death in this sample is not representative of risk in this population as a whole. It's because we've identified the sample using both national birth records as well as the MBRRACE perinatal deaths database. And that's because we found that in the national birth records, they capture the mother's country of birth, but they don't regularly report on language, which made it difficult to identify the sample for this inquiry, and therefore we worked in tandem with the perinatal confidential inquiry team, and they will be releasing a report on the 12th of December, which will complement the findings today and include a further deep dive into the care of mothers whose babies had died. And the next slide, please. There were 2 main themes to emerge from the confidential inquiry. The first was around the need to assess, document, and provide support for language needs, including interpretation and translation at all stages of maternity care. And the second was around supporting women to be able to access maternity services. If we go to the next slide, we'll be able to see a vignette, which is a brief description of the care provided to a woman during her first pregnancy. I'll give a few minutes for people to read this, and then we can talk through the learning that we can identify from this woman's care.
I think some people are having problems seeing the slides. Yeah. Is anyone able to put into the chat that they can see the slides, just so that we can figure out if? Right. Yeah. Okay. Quite a lot of people can see the slides. So what I'm assuming is the people that can't see them might have limited resources on, like, limited internet, or it does seem like the bulk of people can see them. So yeah, maybe if we try resharing them, Catherine.
Yeah, it may be about when I share them and when people join, something like that. So I'll start from the beginning again.
Brilliant, thank you. And we will share them after the session as well. So hopefully you'll be able to get, even if you can't see them, you'll be able to get the bulk of the content, and then we can follow up afterwards. Doesn't massively assist with your slides, Nikki, where there's quite a lot of content around the vignettes, but hopefully people will be able to see them.
I'll flick through them all really quickly now, so you can see what they did look like if you missed them the first time around.
Okay, can someone who couldn't see them before just add on the chat if you can see them now? Love, I
Thumbs
saw
up.
a little floaty thumb. Perfect, thank you.
Okay, so what we see in this vignette is that there's lots of several messages we can take regarding language needs and how they are met with the care that's being provided. If we go through to the next slide. So for the majority of women whose care was reviewed in this report, they did not have professional interpretation provided consistently, either in person or on the phone. And in 61% of cases, a family member interpreted on at least one occasion, including during some sensitive or critical discussions. For 6 women, they were never or very rarely seen without a family member there. And we know that within NICE guidance, there's a recommendation that every woman should have a one-to-one consultation without her partner, family member or guardian there on at least one occasion to facilitate discussions of sensitive issues. The assessors who were going through the case notes felt that the use of family members heavily as interpreters may have led to potential safeguarding or issues or sensitive issues not being explored for many of the women. In this case we've just read, we also saw that there was not proper interpretation support during sensitive discussions, including for ultrasound results or stressing the importance of fetal movements. And again, this was common in the cases that we reviewed. The reviews really emphasised that for any critical or sensitive discussions, not only should there be an interpreter present, but we also need to use closed loop communication, so to check that the information that's being given has been understood as well and heard. And this is also echoed in existing guidance from NICE. For almost all of the women whose care we reviewed, they received written information in English. This was including written consent prior to procedures, or, for example, large amounts of written information when they were going home from hospital with their new baby. This occurred even when it was known that women did not have the language competency or literacy required to read and understand that house-related information. We know from there's guidance from the Office of Health Improvement in Disparities that health information should be translated and that understanding should be checked. If we move on to the next slide, the second key message that we get from this inquiry was regarding access to the NHS and how to navigate maternity pathways. We'll see a vignette on the next slide, from which it was clear that the woman's care, that she was not aware of how to navigate to NHS pathways, or that there were barriers that prevented her from doing so. I'll read it out so that people who haven't got the slides can hear it. So a vulnerable young woman from Romania was living in temporary accommodation with her partner and 2 children. They'd registered with social services, but did not have a GP. The woman reported her pregnancy at 26 weeks gestation when she attended the emergency department for an unrelated minor health problem. A booking appointment was made that included transport and interpreting services, but the woman did not attend. A safeguarding midwife visited in person and informed her of her next appointment using an interpreting service. Booking and ultrasound were completed at 28 weeks of gestation using a telephone interpreter. 3 weeks later, the woman gave birth in the community, 2 days before her next planned visit. Resuscitation attempts were made, but the post-mortem confirmed that the baby had died a week before birth. A telephone interpreter was used to explain the events and to request consent for post-mortem. The woman did not attend hospital for the postnatal follow-up. So although this woman was known to social care, homelessness support and had a health visitor, she was not registered for a GP, and this was true for many of the women whose cases we explored. There is already existing guidance within maternity services which states that women should be given information on their entitlement to healthcare, and that this includes GP practices which are not required to ask for proof of address, identity or immigration status, and that women should not be refused care on these grounds. As in this woman's case, more than a third of women sought care via emergency units, and it was evident from many of these cases that they had not been provided with the necessary information about how and why to access antenatal services, as in line with recommended NICE guidance. And this also resulted in missed opportunities for safeguarding as well. For many women, there was evidence that there was challenges accessing care, shown by booking later in pregnancy or missing appointments. And the assessors identified many barriers that might have contributed to this. So, for example, having text message reminders sent in English with the information around appointments, resulting in the exclusion of women who are unable to read those messages. And also financial constraints in limiting travel to many appointments across different services in different geographical locations. Within the MBRRACE report, we were clear that when women don't attend appointments, it's really important that we explore why, and that we are sensitive to the challenges that may be behind that non-attendance, and explore alternatives that might make it more accessible for women to attend maternity care. And that includes being really careful and considerate with the language that we use around engagement and compliance, and framing it so that there's no blame placed on the woman. Despite all of this, we do know that even within that vignette and many of the others, there were examples of good care, where consistent and quality interpretation made a real difference for the care for the experiences and the outcomes of women. We know that having improvements for the cohort that we looked at, the sample of women, around 66% of women may have had a different outcome or a different experience of their maternity pathways if there was improvements to her care. So there is a space for which we can improve things if we can get that right. Handing back to Naomi now.
Actually, to me, thanks, Nicola.
Oh, sorry, Kirsten.
No, that's absolutely fine. Yeah, thank you so much for that. Some really powerful findings in there, and raises some big questions, as well as providing us with some clear direction. For those of you who don't know me, I'm Kirsty Kitchen. I'm head of policy and communications here at Birth Companions, and I've been involved with the MBRRACE maternal mortality report for the last 5 years. As Naomi said at the start, I know personally how influential this report is, so I'm really grateful that MBRRACE has worked with us on this and have come along to share the findings today. So a really powerful summary of some very big stuff to unpick. And unfortunately, I'm sure I'm not alone in feeling very saddened and angered by some of the things that Nicola has just described, but also quite unsurprised by the MBRRACE chapter this year, because we know how bad things can be for recent migrant women. We know that because of our services, because of what we see in our services, and also because of the great research that has been done already in this area for quite a number of years, and which is being built on now. I think the number of previous MBRRACE recommendations in this space also shows how much we do know. And we at Birth Companions have published a number of reports over the years that have highlighted these kinds of issues. And there's been great work by other people in this space as well, including the team that produced the guidance on interpreting the services through the London Maternity Network, which is highlighted on this slide. As Nikki said, there's also a lot of good work being done in this space, not just on the policy and the evidence side, but also in terms of practice and frontline support. Unfortunately, a lot of that is being done in spite of the systems that it sits within, and a lot of that good work is being done in ways that compensate for the hostile environment policies that dictate so much of what these women experience. But one woman in a discussion in a Birth Companions service recently described how amazing her interpretation support was during her maternity care, and the huge difference that made to her experience of that care, the outcomes for her and her baby and her wider family. It's just unfortunate that discussion was then followed by several other women in the group describing how they had no support to understand or navigate their maternity care, exactly as Nikki has just outlined. So I think one of the things that I take away from all of this so far is that we know that muddling through happens a lot. It's really commonplace. And I think it's really sad that for so many people working on the front line in very pressurized systems, that the sort of muddling through feels like it's an inevitability. There is a piece going up from us at Birth Companions on the British Medical Journal today, which responds to the MBRRACE findings, and in which we describe the fact that inequalities are not inevitabilities. And I think it's very true, as Nicola just said, that there is a huge space for improvement here. We can tackle this, but we need to do it strongly and together. And the reports that are on this slide and many others kind of capture some of what can be done to change this, as well as the severity of the poor experiences that many women face. If we go to the next slide, Catherine, I've just pulled out a few quotes from those reports, and we can share links to those reports in the follow-up email. But for instance, women say, everyone was kind and tried to explain language was a little problem. I was lucky I got an interpreter when I was first seen, but not at the birth. And I think that's really clear as well, that there are points where it works and then there are points when it doesn't. And I think MBRRACE this year particularly emphasises the fact that in unplanned care and emergency care, that was one of the places where interpretation falls down. One woman talks about leaving her baby without food for hours because no one explained to her in a way that she could understand that feeding was expected every 2 hours. Women describing a feeling that they were spoken to in a rude way, that they were being judged. And that's one of the MBRRACE findings that we haven't touched on particularly yet today. There were also findings in that chapter about women's experience of discrimination, bias and racism on the grounds of their ethnicity, their migrant status and their language abilities. And I think that sense of judgment comes through in the other quotes on this slide. It's really shocking that 61% of the women whose care was examined in this chapter didn't have or had to have a family member interpret for them. One of the women in the reports that we will share after this described to us having a teenage son translating for her during a cesarean section, which just shows how inappropriate and unsafe relying on family can be, not only in terms of domestic abuse, but also in terms of protecting those family members from experiences that they shouldn't have to be involved in. And also, it's deeply unsafe in terms of the accurate presentation of often very complex and critical health information. I'll also never forget a woman describing to us that she'd been asked by a midwife to monitor her fluid loss during labour by using a sanitary pad. And the interpreter explained that to her in a way that meant that she inserted a tampon for several hours, and then no one realised until she had another internal examination and they withdrew a tampon. And I think that's just, a very stark reminder of how complex these things are and how often, unfortunately, interpreters might be, very well versed in their languages, but not necessarily in the minutiae of maternity care and practice and what that looks like. So we know a lot. We know a lot of bad things, but we also know that it can be better, and it often is for many women. But we also need to know more, and we particularly need to know more about the way that some of these issues link up. So language, housing, poverty, and financial destitution, experiences of interpersonal bias and racism and structural bias and racism, and the policy solutions that are kind of open to us. So that feels like a good point for me to hand over to Hannah and Zainab to talk about the brilliant work that they are leading and which we're really happy to be part of at Birth Companions.
Thank you very much, Kathy. Good afternoon, everyone. Thank you for giving us the opportunity to share our work with you today. My name is Zainab Barry. I am a visiting research fellow at King's College London, founder of Susanna Berry Consulting, and also the patient and public involvement and engagement, what we call PPIE, advocate for the program that we are about to share with you today. Over 2 million migrants in the UK are undocumented, and their visa states no recourse to public funds, or NRPF, meaning both groups are unable to access most welfare support paid for by the state. This often results in financial hardship, poor housing, isolation, and a lack of access to healthcare and support services, placing them at risk of poor health. They are also required to pay to use many NHS services, including hospital treatment and maternity care. Migrants with poor health are more likely to be women, children, underrepresented ethnic and low-income groups, and people with impairments. There are also differences in what support they can access across the country. A quarter of migrants with NRPF are women and children, but very little is known about their health and social well-being during pregnancy and the early childhood years. For many reasons, including fear and distrust of state services, many women do not access essential antenatal care. Research into maternity services has found that a lack of professional knowledge and guidance to meet the needs of pregnant women, migrant women, needs to be considered. So the aim of this 5-year program of research led by Dr. Hannah Raymond-Jones can be divided into 2 parts. The first is to undertake research on how policy impacts migrant women and children, while the second part is to improve the health and well-being outcomes for women and children at the age of 5. Funded by the National Institute of Health Research, NIHR, this is very much a collaborative piece of work that involves experts by experience, healthcare professionals, national research and academic institutions, campaign and policy-focused groups, NGOs, and relevant academics. Hannah and I meet with the Policy Advisory Group that we call PAG and the Expert by Experience Group, or the PPIE Group, separately and on a triennial basis. Expert by Experience have been supported with public speaking skills enhancement and were invited to take part in a very productive training day where both groups interacted and shared best practices. My role also entails providing them with mentorship services. We would really like to reiterate our thanks to everyone involved and highlight that we would love to share, to have more Expert by Experience people in our PPIE group. So if anyone is interested here, please feel free to reach out to me and Hannah, and we'll give you more information. I think that's it from me, and I'll now hand the floor or the online platform to Hannah, Dr. Hannah Raymond-Jones, who is the program lead. Over to you, please, Hannah.
Thank you, Zainab. Hi, everyone. Good. Oh, lovely. Next slide already. Thank you. Yes, I'm Hannah. I'm a midwife and a senior research fellow at King's College London. So just tell you a little bit more about what we're doing at the moment in this 5-year programme of research. So we're only a year in. And before we kind of analyse the UK data and find out what's happening with the no recourse to public funds policy in terms of women and children's health outcomes, we felt that it was important to look at the wider context. So we're currently in the process of publishing a really large literature review that reports on migrants' maternal and child health and wellbeing outcomes in all high-income countries in the past 10 years. So we looked at what research was out there and we pulled all of that data together to test the so-called healthy migrant effect. So those of you who are unfamiliar with that term, it's a theory that suggests that migrants' health is better than native-born people's health. And some of the reasons put forward for that is that migrants return to their country of origin when their health deteriorates, that they might have healthier lifestyles and protective cultural and social factors, and that those who choose or are able to migrate are younger, healthier, and better educated. However, this effect is thought to diminish over time, and it doesn't hold for forcibly displaced populations. And we also have no idea whether it holds for maternal and child health outcomes. So that was a key aim of this. We also wanted to see the impact of immigration policies and healthcare coverage in these high-income countries, and if it has any difference, makes an impact on outcomes. So we found 39 studies from 16 high-income countries reporting data on over 1 million migrant women and children. When we pulled all of that data together, we found that compared to native-born women, migrant women were more likely to be Black, Asian, Hispanic, or of a minority ethnicity within that host high-income country. Over 20 years old, they're more likely to be uneducated, have children already, and of low socioeconomic status. So these characteristics are already kind of refuting that healthy migrant effect. But the migrant women were less likely to smoke during pregnancy. When we had a look at outcomes, on average, migrant women were statistically more likely to experience emergency cesarean section, poor mental health, intimate partner violence, and their babies were more likely to be born in poor condition. They were less likely to experience preterm birth. However, when we looked at the countries with particularly hostile immigration policies and poor healthcare coverage, migrant women were more likely to experience fetal loss. So the overall conclusion of this literature review is that the healthy migrant effect does not hold for maternal and infant health and well-being. Perhaps the most important finding from the whole review is the huge gaps in evidence there are here. So many high-income countries were not represented in this review. The research just isn't out there. That includes the UK. One of those 39 papers came from the UK. Most of the research focuses on infant outcomes, less so for maternal health, and there was only 3 papers looked at child health outcomes. That was up to the age of 5 years old. And well-being outcomes are particularly absent from the literature. So, there's hardly anything on things like food insecurity and housing for migrant women and children. Also, there's very little evidence coming out of countries with more inclusive immigration policies, which probably just, reflects the context at the moment, that more and more countries do have these very restrictive policies. Next slide, please, Catherine. So just moving forward, next steps over the next 4 years, we're planning to fill some of these gaps by analysing UK data. That will be early next year. So we will look at the impact of the NRPF policy and the NHS charging on a wide range of maternal and child health and wellbeing outcomes. Within this analysis, we'll also look at the impact of a range of intersecting factors. So that will include ethnicity, socioeconomic status, education, people's reasons for migration, the length of time they've been in the UK, generational differences between first, second and third generation migrants, and of course language barriers that has come up a lot already today. We'll also be interviewing migrant women across the country to get a better understanding of their experiences of accessing health, social care and local authority support. And we'll be speaking to healthcare professionals and social workers about their knowledge base. So if anybody is on here at the moment and fits one of those and would like to come and speak to us, it would be wonderful if you could join one of our focus groups in the coming months. So we will use, as Zainab said, we'll use these findings of all of these kind of different strands of the research to inform policymakers and develop guidance for both migrant women, their families and professionals that care for them around accessing care, charging support options and the wider legal framework. And we will continue to work with birth companions and our other partners to share these findings as we go. But please do get in contact with us if you'd like to know any more or get involved. I'll hand back to Kirsty. Thank you.
Thanks, Hannah. And I think you've already got some volunteers and interested people popping up in the chat as well. So yes, we'll certainly share information about how you can get in touch and play a part in that research in the email that goes out after this session. I think what Zainab and Hannah have just captured really well is the fact that there are huge gaps in the evidence, and there are huge assumptions being made about the experiences or needs of migrant women and babies that it seems are unfounded or based on sort of misinformation, really. And what's really crucial is that we need to close the gap that exists between that sort of big picture evidence and the realities of what we and many other people on this call will sort of see on the ground day to day, because we do know a lot more than the evidence, the sort of formal evidence tells us, I think. So we need to close that gap. But in terms of sort of based on what we do already know, what could happen now, these are birth companions kind of positions, not necessarily the positions taken by other contributors, but we firmly believe that obviously we need large-scale investment in delivering a safe, trauma-informed and equitable maternity system, and that would benefit everyone, but obviously would benefit those who are currently the most disadvantaged by that system really significantly. It seems absolutely clear that we need an urgent national review of interpretation provision. There's been some brilliant work, and I mentioned the toolkit that was produced by the London Maternity Network, and I think Rebecca Gilbert is on the call today, who helped lead that work. There's some great guidance out there. There's some great support. There's some great knowledge, and it's not translating into practice across the country. And we just can't allow that to continue. We need some really concerted and coordinated national action on this. And I believe that there are conversations happening to push that forward, but I hope that it grows quite significantly in the coming months. We would absolutely advocate for an end to NHS charging for migrant women in maternity care, and also a very sort of immediate level as well. We believe it's long overdue that NICE guideline CG 110 should be reviewed and updated. That's the guideline that is on pregnancy and complex social factors. That's the guideline that includes reference to migrant women, and it was published in 2010. It was reviewed in 2018, and the reviewers said that there wasn't enough evidence to inform an update, and that's 6 years ago. And while there are still gaps in evidence, as Hannah's just very clearly pointed out, there is a lot more evidence available than there was, and also the policy space has shifted hugely since 2010, and we need NICE CG 110 to reflect that. We would absolutely call for the abolition of the no recourse to public funds condition on migrant women. For those that are interested in this, there's a great analysis done by the London School of Economics that shows massive net gains over 10 years by removing that condition just from households with children and vulnerable individuals, as they term it. So it's not a cost to the public purse, it's a net gain over 10 years. It's still a net gain if you just remove it from everybody. But certainly as a priority, we would argue that condition should be removed from families. And until that happens, I think this has come across quite clearly in some of the discussions through your research, Hannah. While there is still a no recourse to public funds condition, we need to look at affordable childcare and support for women with that condition applied, because they're massively disadvantaged at the moment. And thinking more widely, we need to end the use of hotel accommodation for migrant women and their children. The conditions, as I'm sure many are well aware, are absolutely shocking in much of the hotel accommodation that women are forced to rely upon. And there's a great report from Women for Refugee Women, who are good friends of ours in this space, calling for exactly that. And so I would direct you towards that, and we will share a link to that. The case study that they include in that report of a woman with a young baby navigating that hotel accommodation is really quite shocking. But the housing reforms need to go wider than just hotel accommodation as well. So there's a lot of issues with unsafe and inappropriate housing options for pregnant women and mothers of young children who have recently migrated. So as Naomi said at the start, we're planning at Birth Companions a very big focus on this area in coming months and years. And some of our partners in that work, including Happy Baby Community and Hannah and Zainab, have joined us today. We expect this to be an ongoing conversation, and we would love many of you who have joined this event to come on that journey with us. But I'm delighted that we've got 16 minutes for some discussion, whether it's answering questions or sharing reflections that have been shared in the chat. So Catherine, if you have been able to kind of keep an eye on that, maybe we could dive into discussing some of what's been shared.
Yeah, absolutely. There's been lots of really lovely not all lovely. It's lovely that you're all reflecting in the chat. Lots of sharing knowledge and insights and practical on the ground experiences. I'll run through a few of the reflections that are there, and there's not so many questions, but I can put them to you as a group and reflect back. So Maria has said that she's done some baseline work in preparation for a PhD that found that women with English language needs are overrepresented in maternal death data by 25 times more than those without language needs. And I think that's had a lot of interest in the chat as well, and it'd be great to hear more from Maria at some point about that project as it goes forward. I wonder if Nikki, how that kind of fits in with the MBRRACE data.
Yeah, I think it aligns completely with what we see across not just this report where we've had the specific focus on within this confidential inquiry, but within many previous reports where we often see that recurring theme around language needs not being met, and then a disproportionate representation of women with language needs within the cohort. Although what's really challenging is to be able to kind of do that analysis. We need to know language needs of everyone giving birth, and it's not recorded routinely but very well, which was one of our main kind of recommendations of the report, is that we have to do better at asking what language she needs and recording them consistently, not only so we can provide a good service throughout pregnancy, in emergency situations and in routine situations, but also so that we have that data to make the case for having this system level changes to make sure that those services are available.
Can I just make a point off the back of that as well, share a reflection. I think one of the conversations that is often had around the poor recording of domestic abuse needs in maternity care is that sort of like chicken and egg scenario, where there's a sense that staff don't want to ask the question because they actually then don't feel confident that there's an awful lot that can be done to provide the support that women might need if they disclose those experiences. They're either not confident in their own ability to respond, or they're not sure that the service provision is out there to help women then deal with that situation. And what I'm questioning in my head is, to what extent is the sort of lack of confidence in the interpretation services that we have access to in the healthcare system playing into that hesitancy or reticence around asking about what the language needs are? If we had a really strong provision in place, would there be better inquiry about what women really need? Because you'd think that then you can put in place something that responds to that.
I was thinking to let Hannah answer, but I completely agree that I think that it really plays in together in exactly the same way. You know, you want, in order to ask a question, you want to be able to know what you're saying in response and feel confident in that.
Yeah, I think, you know, you can see this in many different situations, can't you? For example, places that don't have good smoking cessation, people won't be asked about whether they smoke or not, because you can't do anything with that information, and that plays out with intimate partner violence, migration status, language needs across the board. So it's really looking at what services are there and what support is there before we go and ask people things.
A lot of what you just said as well, Kirsty, really reflects what's been going on in the chat. I don't know if you've been scrolling through, but we've had a few comments from people reflecting on similar things. That Emma Rose had said that midwife members, I think Emma's at the RCM, midwife members often report that they struggle to reach appropriate interpreters at appointments. They get put on hold, no interpreters are available, interpreters end the calls. Lots of examples of poor practice there, and then practical things about booking systems not working, automatic pre-booking not happening, and that so yeah, just exactly as you were saying, that kind of that's, I'm sure, just building this sense of lack of trust or lack of confidence among those midwifery professionals. Kind of off the back of that, I think Zora has reflected that interpreting services have mostly been outsourced to private agencies. There's a lack of training. Qualifications and training courses might be too expensive or not accessible for members of the community with appropriate language skills. Interpreting is not a full-time job, so interpreters may not always be available, as they need to have other jobs as well. So then the provision of interpreters and their status needs to improve. So I think it's a really sort of additional, looking at it from the interpreter's side as well, from that industry as well.
Yeah, and I think there's some work underway that I have not yet connected with, but I've got meetings coming up to sort of engage with work being led from the interpreter's side as well, in terms of standardisation and sort of professional responses to this, because I think there's a lot of sense that good interpreter provision is being undercut by other providers that provide a cheaper service, but not to the same standards. So I know that certainly within the industry there are efforts to address this as well. Sorry, Zainab.
No, that's okay. That's a perfect segue to what I was going to say. And thank you so much, Kirsty. I think that's it. It's about locating the responsibilities. I think the theme for me here is that there's a lot of assumed delegation. There's a sense that instead of coordinated efforts, the system is divided in different silos. So I think it's really important for midwives to be supported, for the translators to be supported, for the women who are coming to be. So it's an all-in, it's effort for everyone basically. So I think that's where we need to focus on, because it takes a toll on the women who are having to go through those appointments without being supported enough to be understood. And it's the same also for midwives who sometimes do not have the necessary financial or emotional support or cultural support, cultural intelligence support, or maybe even logistical supports. And also it's the same thing for, the same can be said for the other professionals on the other end. So those translators, yeah, I think I just wanted to make that point. Thank you.
Yeah, and so I think what we're talking about is a complete kind of culture shift, isn't it? And this relates back to that set of findings from the review of the care of these women in MBRRACE that relate to stigma, discrimination and bias and racism, because part of the culture shift needs to be a complete step change in the degree to which these women's experiences and outcomes are valued and prioritised by the system. And if lots of people at lots of different levels are not prioritising that or valuing that experience, then it's going to be impossible to bring around that kind of that shift, really.
Thanks, everyone. There's so much in the chat. It's hard to keep up. I'm really pleased everyone's sort of responding to each other and building on things. There's quite a lot of links being shared as well, so we'll gather them up and make sure everyone's got a list of those afterwards. I can see a more direct question from Melina, which is, do you have insights into the experiences of women under temporary protection policies or with unstable asylum situations or at risk of being deported, and whether them being pregnant or having infant children weighs as a factor in these procedures? I don't know who would most like to jump in on that one.
I mean, this is something that we are planning to look at. We're trying to access these women to get their experiences. We've worked with Project 17 to get some insight here into actually what happens to these women and if pregnancy does make a difference. To be honest, I don't think it makes a huge difference to the level of support they get, but we don't know, and there's such a lot of variation. So, you know, Zainab and I are working hard over the next few years to try and reach out to women in the most precarious situations here.
Yeah, I would just add to that that I think it's a level of detail that we don't have, but I think it flags up. We see those experiences. We see women in those situations in our services, and it reminds me of the importance of flagging out the fact that women's status changes, and it can go from insecure to more secure, but then it can go back to insecure status as well, particularly when women's status is tied to their partner. And we certainly see women's situations unravel very quickly with, you know, huge trauma and, you know, huge sort of consequences for them and their children through our services. And I think we need to recognise it's not just a kind of one-way, it's not a one-way journey in terms of migration status.
Thanks, everyone. So we've got 4 minutes left, and I can see that I think Nirupama has her hand up, or your hand up. I think I can allow your mic if you'd like to, if that means you'd like to ask a question out loud.
So I think you just need to unmute now at your side. I think
I've given you permission. Oh, hi.
Hello. Hi. So I wanted to say that my name is Nirupama, and I'm a steering group member of Nurture. And I was there with Belinda at the research when you presented some of some of these slides that you showed today. When you presented this at the research conference last Monday at King's College. So I wanted to say that I'm heading the healthcare collective for the London Mayor's London Migrants Advisory Panel, and maternity was one of the topics that I raised, and it is in one of the priorities for to look into for this year, 2024-2025, and I'll be more than glad to feedback in any of the reports that you could provide me. I've got the MBRRACE report, and because I am with Nurture, I've asked them for documents as well. So, if you can provide some data as well, it would be really helpful that I can feedback in. And because we sit with the GLA officers who deal with maternity, so it would be really insightful for them, because they did not know about Neom Nurture when I told them about Neom Nurture. So I'm not sure if they also are aware of MBRRACE and the report. So it would be really helpful, to feed into them and see what they can do for us as an organization, because they are policymakers, so policy advisors rather. So it would be really helpful. Probably could be really helpful for women who are going through this trauma of birthing, which they should not. I mean, I'm a migrant mother as well, and I went through that, and it was traumatic. And I didn't, and I'm also a victim of domestic abuse, and which also made me become an IDVA. I'm now a specialist IDVA, and that is purely because of what I went through. And now I help a lot of other women, and and as you had mentioned, as someone just mentioned now, when the visas are tied to their spouse, it becomes even more traumatic for them. So it's kind of very inconsistent. They get in a very inconsistent situation there, and it's not pleasant for them. So domestic abuse and maternity was a topic that I raised. So if you guys can feed me in, and I'd love to be a part of the focus group meetings and the research if possible. Yeah, either as a steering group member from Neom Nurture, or as and as somebody from the MAP Migrant Advisory Panel. Thank you.
Thank you so much for sharing that, Nirupama. I think that you will certainly be hearing from Hannah and Zainab, and we'd really like to connect with your work as well. Sounds like you're doing fantastic things, and I'm amazed that you've turned such a challenge into such amazing work. So thanks for sharing that.
Thank you. And I forgot to mention something. There's one last thing that I want to mention. I devised a more like a service design for the migrants, with it's more like a navigation tool for NHS, but the GLA are not really how do I put this properly? Right. They're not ready to fund it, but I can share that with you. It is a service, it is a navigation tool that would make migrants from other countries, when they come migrate into UK, it's more like a comparison study of of how NHS works, and what to expect with NHS and what not to expect, and when to go to A&E and when not to go to A&E. It's more like literally walking them through. And it is not just I have service designed this as an app, and I'm working on this independently, because GLA has said no to it. I thought I might as well do it, and I might as well put it out there. So it is also audio visual, because a lot of migrants who come in, they don't know how to read or write. So it would be better if it was audio and visual. So this is something that I can, we can explore as well. I'm more than glad to share these details with, these designs with you, and see if it can work. If it can work, it can work. And we can also probably design something similar for migrant mothers that could help them, because a lot of them do not know how to read or write. So if it could be something that has audio and visuals, it could probably help them.
Nirupama, that sounds so exciting, and please do share details, you know, with Hannah and Zainab and with us. That sounds brilliant. I'm going to bring the meeting to a close now, and we've gone a little bit over. Apologies for that, but thank you so much for coming. It's been really great to gather together and to obviously hear from our expert speakers, but also to gather all of your expertise, your reflections. Just a very quick thing to say that of course we plan to take this work further. You know, obviously there's the research, but also Birth Companions work with partners in this space. If you'd like to find out more, like to keep in touch with that work, then please do sign up for our newsletter via our website. We won't bombard you with information, but we will give regular updates on what's happening in this space. So, you know, if you'd like to hear more about that, then please do sign up. Thank you so much for coming. It's been great seeing you all. Have a great rest of your day, and I hope to see you soon another time. Thank you.